Hi, George. How are you? You
Good,
know,
good.
we're so happy that we're back with you guys at Arch and are able to show an exemplary live case. All of us here, myself, Dr. Guja, Dr. Kapoor, Dr. Sharma, Dr. Kinney, really want to congratulate Jazz. Jazz, it's incredible what you've been able to do on this particular day, in this particular time, in this difficult period during this COVID crisis and pandemic, to be able to pull off such a fantastic meeting. I do want to say that we've been watching along the whole day, and it's been an incredible day of learning for all of us as well. And all of us, especially the three of us in this room, really are grateful to you and George and the entire panel for really giving us the privilege of being able to do this live case and send it to you and contribute to your meeting. Without further ado, I want to introduce our team. I know that most of you know them well. To the back is Dr. Karthik Guja, who
Hey, George.
really everybody knows everyone. He's the assistant director of our program. To his left is Dr. Vishal Kapoor,
Hey, George.
who is the director of Mount Sinai St. Luke's. And also is an integral part of our team. To my left is Ray Lascano, who's our endovascular nurse practitioner, has been part of our team for many, many years. Behind him is our fellow, Dr. Amit Huda, who's an interventional fellow here with us this year. We're privileged to have him, and he's going to go on to do a structural year with us. Behind me is one of our two endovascular fellows, Dr. Sriya Avadani, who is again spending a year learning some advanced endovascular techniques. Our nurse is Elizabeth Holton, and our tech is Damien Cabrera. And I would be remiss without introducing Raman Sharma, who's our other endovascular fellow, who's not in this case. And very importantly, Dr. Sardar Farhan, who's an integral part of our program as well. But George, from the long introduction, I want to introduce the case to you. I do want to say one thing, that we know that it was supposed to be an SFA case. Unfortunately, our patient, for personal and other medical circumstances, couldn't be here. But we have a great case anyway, and I'm going to ask Sriya to go ahead and present it. Sriya,
Excellent.
Hi, everyone.
come stand here.
Yep.
Yep.
So, sorry, a lot of wording on the slide, but our patient is a 77-year-old woman with a history of PAD. She's had prior below-the-knee interventions, who came in essentially for a non-healing right foot ulcer on the hallux associated with rest pain, putting her in Rutherford class 3, category 5, Fontaine class 4. No motor or sensory deficits, and she just had worsening pain over the past few weeks. Past medical history, besides PAD, she does have coronary disease. She was also had an left iliac vein stent placed in about a couple months ago for May-Turner syndrome, and diabetes and AFib as well. These are her medications. On exam, as you saw in the picture before, she had a hallux ulcer with dry gangrene at the tip. She also had some areas of erythema and tenderness to palpation in the 4th and 5th digits. Lab-wise, no real white count. Her hemoglobin was 9.9, and these are her other labs. She did get a foot x-ray that showed soft tissue edema and ulceration, but no radiographic evidence of osteo. ABIs on the right was severely reduced at 0.57, and on the left was 0.71. She did have evidence of an occluded AT and PT on the right, on the arterial duplex. As per the Wi-Fi classification, we categorized her as a wound class 2, ischemia class 2, based on her ABIs, and foot infection that was mild, which puts her at stage 4, high risk for amputation. She did have a peripheral angiogram that was done via left radial approach with the pigtail and the descending aorta. Iliacs are, as you can see, very tortuous, but no focal disease. Left side was pretty patent SFA and popliteal. She did have some evidence of below-the-knee disease with a dominant perineal.
Go to the next.
And this is her right lower extremity angio. Again, above the knee, patent, no significant disease.
So George, I think for the sake of time, we're just going to go forward. Can you go to the live, please? I want to show you what we did. She's just going to go over the anatomy. So you can see here that on the live screen, can you show the screen, guys? you have a severely occluded, a tortuous iliacs. Can you show us the live screen? George, can you see the angiogram or no?
I can't see the angiogram right now.
Okay, well, you saw the angiogram from what Sriya showed you. Very, very severe tortuosity of the iliacs was present, and then the SFA had no disease. So we went ahead and we took some below knee pictures, which I really need you to see. Okay, there we go. Okay,
There you
so we put a long sheet because of the tortuosity of 55 centimeter, and then we went ahead and did a shot below the knee, and you can see here at the level of the pop, as you can see clearly, she has a severely diseased AT, which comes all the way down, and then she has a PT that also occludes, and so I'm sorry, and then we went ahead and took a shot of the foot. And you can see the foot really has she has the perineal that fills, the PT that comes back, and the AT that fills very, very, very slowly, and then a very, very faint dorsalis pedis in the foot. Now, what I cut off Sriya was going to talk a little bit about angiosomal, and I think we should talk about angiosomes. And she had a nice slide that showed, Sriya, can you talk about that slide?
Yeah.
Which showed the angiosomes. Can you go back to her slide deck? Yep. And you'll see in the slide deck. Next one. This is your deck. Yep. Go ahead.
There we go.
So based on the location of the ulcer involving the hallux and also the digits, we felt that both the dorsum and the plantar aspect of the foot was involved. So kind of AT and PT territory really.
So
based on that.
so it's a watershed angiosome, and so we decided, Vishal, myself, and Karthik decided to go after it, and so we decided to do some things offline. As you can imagine, cases like this can be tough. So we went ahead and we went with a. Can you go back to the angiogram? So we decided to go ahead. This is our foot shot here. You can see very poor filling of that distal posterior tibial. But there seems to be a lateral plantar and a medial plantar artery that are open. The dorsalis pedis does come back, but very, very slowly. And you can see the foot is really supplied more by the posterior tibial than the dorsalis pedis at this stage. The arch is a very, very poor arch, as you know. Next. So just before our discussion, I want to tell you what we did offline. We went ahead and took a selective shot of our posterior tibial. You can see our posterior tibial comes down and occludes right in the mid. Next. So what we decided to do was go ahead and look for calcium. And as you guys know, some of the tips is you look for some calcification and try to follow. Next. So we bought a coronary confianza wire. As being cardiologists, we are very, very comfortable with those, as you know. And we went ahead and bought the confianza down and keep going. And you can see, George, we were not making much progress. We keep getting stuck right at that level of that distal cap. It kept going into those collateralizations. Next. So at this stage, we pull back. Next. And we decided to do fluoro on fluoro. And you can see here, you can see the calcification very, very clearly. And we are outside the vessel. Next. So at this stage, we pulled back the confianza using a teleport catheter to give us support. Next. And we were able to steer the wire back into the skeletalization of the posterior tibial. Next. At this stage, we were able to wire down, and this is a nice picture because actually you go now. Oh, yep, we pulled back, and then I guess the Flora saved it, and then we were able to go back down with the wire and try to go ahead and keep it within that calcium. And this is kind of the advantage you and I have in the peripherals versus Jazz. And you can see we kept going down into the wrong area, and then we pull back again. We look pretty good there, but you'll see what happens next. So we went down again in our high flora. You can see we're outside the vessel. So again, next, we pulled back again and we re-steered it. And you can see here again using the confianza. And Jazz will laugh at my curve, but it's actually a very effective curve in the peripheral because the vessels are larger than the coronaries, and we're able to actually torque it through into that vessel because I need a little bit more steerability, and we're able to track it down. Go next. And then once we tracked it down, we got into the foot. And here you can see this is probably just hibernating vessel, George, and Anish, as well as Jay. We're able to just, again, really just slowly wiggle it through that cap, distal cap. And then we're able to follow it all the way down, again, following the calcification. And it's going quite easily here. So we had this segment that was occluded, which was a little challenging. And then next, we then changed that for a coronary fielder wire. Well, here's a picture first. Where Ray's going to show you a picture here. Actually, you know what? Go to the next one. The next picture is better. So then we went ahead, changed that for a coronary fielder next. And the fielder wire really kind of flew right in. Here's a fielder coming in. Oh, this is still this wire. There's still confianza next. And there, the fielder flew right in.
Okay.
So the fielder flew right in, and then next we just show the fielder going in. Just gonna go like a zoom here. I don't know why it's not moving. All right. Anyway, you get the point. Next.
That's good. Yeah.
So then we went ahead, checked our position, changed that for a Viper wire, and we're gonna go ahead and do the Viper with Vishal and Karthik. Vishal, Karthik, one of you guys, can you just talk a little bit about the Viper wire and what we're gonna do here? I know it's different than the coronary Viper. I'm sure they've showed CSI cases, the coronary CSI, than what we did today.
Yeah, I mean the main difference between coronary CSI and here is the Viper wire is the same. It's a long Viper wire, but and then the coronary CSI is limited to classic crown, which is 1.25 classic crown. But for tibials, we have a micro crown, which we have specially made for the peripherals, which is made, and I think that's made the major difference. Is everything else is
it's also the length.
Yeah.
The length is 145.
So the length
right?
is 145, and also we have, I think they now have something made for the radials, which is 200 or 250 longer. So they have like around 400 shaft, which goes down to the level of the tibials from the radials. So which is great for them, and they have this 400 wire, which they came up with, which is good for
this. But just one thing, George, before we go forward, 1 second, I just want to show you what we did, Flora. We put a coronary guide up to take away some of the tortuosity. So this way we have a guide engaging into the posterior tibial, and now we're going to go ahead and Viper. Go ahead, George, and I'm going to let them work as we talk. Go ahead, guys.
Yeah, so I was just going to ask, because, I've talked about this before, the arch of the foot's very delicate. So I noticed the wires into the arch, but you're not trying to go too far down so as to not disrupt things. But the part where you said you re-entered and you thought it was hibernating. So is your plan to do X amount of atherectomy and then kind of see what opens up? Or are you gonna go below the ankle, or do you even know at this point?
Well,
what's your strategy for how much atherectomy you're going to do?
I look forward to Jay and Anish's and your comments, but to me, I felt since it was hibernating, and we've all done a lot of these CTOs in the periphery where you have a lack of flow pressure head, but the vessel itself is not occluded. The wire really showed that we wasn't occluded inside the foot, but the posterior tibial at this area where he's at right now was occluded. So at this stage, what I'm going to do is open this up into the proximal, I would say, ankle, and then go ahead and give some vasodilators and then take a picture. I don't know, Anish and Jay, would you guys do something different?
No.
Jazz?
Go down to the level of the ankle.
I think you're right on it. And the vasodilators are key in this case because with the runoff that you have, there's a high risk of shutting things down. So your technique with the atherectomy would be key, and then also making sure you're giving tons of vasodilators at the end.
Right. So Vishal, can you talk about the technique of your atherectomy? Because I think one of the things that Jay and Anish both said was the technique is very important to prevent embolization. I would go a little bit further down, guys.
We don't have the length, so we are moving.
They don't have the length. Go ahead, Vishal.
So I guess the biggest thing to know with CSI use is you have to be intraluminal. So if you go subintimal and out, usually they would not recommend using a CSI. Or if there's an ISR, then CSI is technically not indicated in those two circumstances. So we just want to make sure the CSI is you cross intraluminal. We go slow, 1 millimeter a second with flush on pre and post. And I guess the most important thing, like how you do in the rota as well, is listen to the noise or the sound. If you feel resistance or the sound changes, you slow down, you do like small pecks to cross the lesion. You don't want to just jump forward and then get stuck beyond the lesion. And the other important thing to remember is never stop your CSI in the lesion as well. Let's say you've done your 20, 30-second runs. You just come all the way back like I come here. We just lock it. We flush it, so make sure it's flushed. And the flush end has two ends, one with the device and one at the main portal area. So we can flush so that the so-called solution can clear off any distal embolization it might be.
So Karthik, can you comment on I know about RotaFlush, RotaGlide, on the CSI stuff that you use. What are the vasodilators we're using?
So verapamil or nitro, like we standardly use.
Okay.
for anything. I think they have a difference in
That's enough.
the egg yolk.
No more than that. Yep.
That's good.
Come back.
You want
I
to
think
go a
we're
little bit
done.
more?
No,
You
No,
can go a
I'm
little
I think
okay
we're
with
happy.
that. I'm okay with that.
All right.
Yeah.
So I
yeah.
think the main thing is deceleration, right? In tibials, we have to worry about the deceleration
Okay.
noises.
All right, let's walk
Let's
it
walk
out.
it out.
If there is deceleration, we just have to.
Yeah, I think this
Karthika.
vasodilators may be more important in these area than coronaries. I think most of the
Yes,
coronary
yes.
rota and with Viper Glide thing, they really don't need vasodilators anymore
Yeah,
because
Correct.
the
absolutely right.
technique and
Yes.
stuff.
So Jazz, that's a great point, but we are now going to inject vasodilators through the coronary guide. That's part of the advantage we have. Obviously, we put the guide close not only for support
You're gonna
with the
lose wire.
tortuosity of the CSI,
No, we're not.
but
No, we
also with the fact that now we can give vasodilators directly into the posterior tibial that we need to do. So I've got 200 mics of nipride.
Got it.
I'm
No,
gonna
keep going.
give a little
Not yet.
verapamil. It's not out yet.
Fluoro?
Not yet.
A little
Keep going. It's
verapamil
okay. I
as
have
well,
fluoro on.
and then we're gonna go ahead and
Yeah,
just flush it
There you
through.
go, Vishal.
Wait. I have it.
Okay.
Yeah.
Let them walk this out. So George, if this looks good, we're going to run a quick IVUS through to show you the size of the vessel. And as you and I know, I mean, one of the things that all of us are guilty of in the peripheral is really undersizing. I'm giving the whole thing, right, guys?
Yes. Yeah.
So give the whole thing here.
the way.
Flush it through, please. Hit the flush.
Flash Karthik.
So the
Yeah,
flush
that's a
is.
great point. IVUS is going to be key here to your next step.
Yep, I'm going to
wanna
give a
give
little
more?
bit of verapamil as well to really vasodilate everything. And we're going to give 1.25. Flush it through, please, because I want to give it to the AT as well. Because I just gave some nipride. She's an elderly person, so I really don't want to drop her blood pressure too much. I'm sorry, hon. Try not to
She's
move.
also bradycardic, so.
Okay. So I'm just going to do now a DSA.
Yeah. That's my
Watch my pressures
one.
on the coronary guide, guys.
Off.
Yeah,
Uh-huh.
we're good.
Good. Good. Ready?
Well, let me fill the catheter.
Fill the
now.
catheter?
Yeah.
Okay, ready?
Yeah.
So again, it's filling down the
see
AT, but the PT is starting to come slowly. And there it is.
Nice.
So now we need to go ahead and balloon this. So let's do a quick IVUS on the Viper.
Yeah.
So now you see, George, the perineal fills, the PT comes slow,
Fix the one.
and now we're going to do a quick IVUS to balloon the to IVUS size this, and then we're going to go after the AT.
Mm-hmm.
So
Sounds good.
025.
so George, I mean Anish, Jay, I mean in your guys' hands, would you have done something other than CSI? Would anybody have just done regular balloon angioplasty and then followed it up by, just maybe spot stenting with a tack or anything like that? A little higher?
I mean, that would be nice to be able to do that. With the amount of calcium that you have there, I don't think you have any choice but to use some type of atherectomy that, that works well with calcium. So, CSI and ROTA. CSI might have a little advantage here because
Ring down?
obviously the whole crown is, is coated. You're going to be less likely to get stalled in there. But, ROTA
Ready?
would be an option as
Yeah.
well.
Live record.
Anish, can you hear us?
Yeah, I can.
okay.
Can you hear me now?
Yeah. Okay. Recording.
Yeah, go ahead.
Yeah, look at the amount of cal.
Just that in crossing that posterior tibial, it goes to show that you really have to be patient rather than trying
Ring
to
down. Ring down.
force your way up there. I completely agree. I think I would have tried a CSI on this one as well. Sometimes the IVUS can definitely help to see if it's more of calcium versus intimal calcium.
Right.
And if it's more medial wall and just mostly with plaque, laser is an option too as well.
2 vessel distally.
Yeah.
Just guys, ring down. You'll see the lumen better.
Yeah. That's what we told
Yeah,
them.
we
to
did.
do.
We
have
told
to
them
stop.
these guys aren't
Okay.
ringing down. I
Stop
don't
1
know.
second.
Stop.
Ring down?
Ring down, please.
Ring down now. Yes.
Okay, good. Thank
Perfect.
you. Let's go.
Go live.
Go live. Okay, but Jazz, I mean, you could see clearly that you have a
Still a
beautiful,
circle
the lumen is there, but it's a very, very small lumen. It's pretty much around the catheter, maybe a 2.0 lumen all the way up until we get into the guide.
Stop.
So I think what I'm going to do here is go with a 20200 balloon to balloon first, and then go with a 2025 210 balloon to go ahead and maybe expand the proximal area a little bit more. I think that's what we're going to do, George, if that's okay with you guys.
Yeah. I was just going to make a couple points. I think the device selection is good because you have to think of it in two segments,
200.
right? There's what you're going to do above the ankle, and then there's always the possibility that you may have to do something below the ankle. And then secondly, what you're trying to do here is heal a wound. So I think, we all sometimes have to keep
Okay,
in
wow.
mind what
Got
the
it.
goal is. Not perfection. The goal is healing the wound at this point, because this is an ischemic limb. It's not a claudicant. So yeah, everything's spot on. I think that IVUS image, when I saw the pullback, I think that the vessel is probably bigger than we think. It'll be nice to see what happens after this balloon inflation.
So you know what we do,
What's the wire?
you know,
What's the
we've
wire?
learned
What's the
obviously is to go ahead and balloon slowly and increase the size of our balloon, sort of like the peripheral vessels, because of this diabetic, you know, calcification. Actually, slow balloon angioplasty really allows for this vessel to enlarge slowly. So we're going to go up slowly with this 2.0 balloon to 8,
Go even a little
and then
bit
they're going to
lower.
have a 2.0, 2.5, 2.10, and then possibly even we'll go with a 2.5 into the foot, George. But
4.
let's see how she reacts. You can see she's having
Sure.
pain already.
Sure.
Just breathe it out, my dear.
5.
So we're going up with the balloon. Guys, can you go LAO so they can see the balloon inflation?
Yeah.
LAO,
LAO,
LAO.
LAO. And cat mode.
Well,
Yeah, I mean, you had a pretty bad 360 degrees of superficial calcification.
5.
And, you know, people think it's deep calcium, but this was all superficial. So I
8.
think doing CSI was amazing. I think the balloon would crack
7.
this area and have very bad flow, limiting the section. So I think that was a good choice.
So my question to you also is, Jay. I mean, what do you think about what do you think about our
8.
or actually all of you? What do you think about the shockwave now? I know the coronary shockwave is there. We've got shockwave below the knee. I mean, would that be something you guys would have considered using?
The problem with using
Yeah.
shockwave here, I think shockwave's fantastic.
Yeah.
It's great to use it, but the length of the S4 is fairly short, unfortunately. So,
Yeah.
it would be kind of cumbersome to be able to, one,
Okay,
deliver
stop.
it there, and two, be able to do effective
Sure.
modification throughout the entire length of the vessel. But it would be nice to be able to use something like that in the future.
Yeah, you know,
Or-
PK, I'm going to show one later, but I think
8.
getting all the way down here would be a little problematic with shockwave, and then Jay's right. I mean, you'd have to do 8 million overlapping inflations, unfortunately.
You'll have to use 4
lithotripsy.
balloons.
And the crossing, with all that calcium, that wasn't, medial, that was obstructing the lumen.
Yeah.
So,
Right.
so you, at some point have to pick
Down.
You have to clear a path for something.
Well, I totally agree. I mean, crossing was, it was, like I said, it was not the hardest cross, but at the same time, it was a pain in the neck because of the worry about going subintimal when we wanted to use CSI. So yeah, I mean, the only thing I was thinking about is with regular balloon, you could have dissections. With shockwave, I'm thinking, because of the way the balloon itself works, maybe dissections would not occur as much. And that's why.
At 2 atmospheres, if you do a few cycles, it's
Put it 8,
pretty
please.
impressive.
Okay. Down.
But the
Okay.
length
you have to
is
use it
problematic.
at least at
Walk
2.5.
it up. I'm sorry, George, we missed it.
No, I was going to say that the at 2 atmospheres, the shockwave works pretty impressively,
3025?
especially if you stay on a few
3025, no?
cycles.
3025
But
to
it's
10.
just the length
Not-
of this
not
lesion
202.
is problematic. It
3025.
would just take forever.
3 or 2, 5, 2. 10.
Okay, so we're decided based on that IVUS, George, to go with the 3.025, 210, maybe a little aggressive, but I think I agree with what Jazz said, that the CSI did a pretty good job. I think we should be able to expand it, and the vessel is probably a little bit bigger than we think it is, and then we're going to get quickly
Okay,
started
we
on
should
the
have
AT, and we're going to cross that AT hopefully in a jiffy, which will help us to take care of that and establish full flow. What is all of your thoughts on angiosomal revascularization? I know Dr. Avadani, our fellow, is big on that and wants to learn more about that. So what are your thoughts in that particular issue? I mean, it would make sense in the coronaries, as all of us are taught by our teachers, that basically, ischemia is there, you fix the inferior wall, so on and so forth. But here, we, as peripheral interventions, we tend to just open the vessel to the foot. So what are your thoughts on doing angiosomal revascularization?
Well, it's so the thing is, it makes intuitive sense, but you have to also, it's in a below the ankle conversation. So if you've got an intact arch, you've got arch communication, then
There.
indirectly
little bit
getting
lower.
to
I'm
that
gonna
same
pull back, right?
territory.
Yeah, pull back.
No, I would go a little
What
bit
the
lower.
data available shows is still a
go
good
lower.
strategy if you
Go to the
can't get
level of the,
direct
plantar arch.
flow
it's
down into
very
the
ragged.
angiosome. So
Too
it's
fine.
sort of a discussion
Slow.
of, do you have an intact arch or not?
Slow. She's
yeah,
having a lot of
yeah,
pain.
Whether
I'm
you
only
be
for-
dogmatic
I know, a
or
lot
not.
of pain, dude.
And I guess, what we'll see is after you do this angioplasty,
I want to
whether
go
or
back a
not I
little.
try to get into the
Can't
pedal
take-
large.
Just till it's so
get to the
diffuse
plantar
disease, we
pedal loop,
dissect everything's going to shut down.
at this point.
No, yeah.
होगा ना
Yeah, I agree. I think the other thing with frequently we in
She's
the
going to pain no
diabetic
matter what, right?
that pedal arch is occluded.
Put me on corner, please.
Yeah.
So I think that's where the concept of angiosomes really comes in, where when that's occluded, when you don't really have that indirect flow going in as well. But I think taking a selective picture, like they said right now, once you're done,
She's going to have pain.
I know it's gonna hurt. More nitride.
So you're having a little bit of pain with the
Sorry.
2530. A little
It's fine.
aggressive, I
It's a
do
big
agree.
vessel,
But
It's low pressure.
we're only at 8 atmospheres
One
here.
second off.
So now we're gonna walk it back.
Yeah.
Sorry, my dear.
Along with the angiosomal concept, I think if you had only been able to open the AT for this patient, you still would have gotten a good result. But I think actually the fact that you're able to get that PT first, and now when you add the AT on top of that, I think you're really offering this patient a great benefit.
The only comment on
6.
that, and the question is, with the watershed area associated with that great toe, do you think it would have completely healed with just the AT, with the arch being so diseased? Down.
1 second off. Yeah.
I mean, I think the arch is key. I mean, you have to have the arch open.
Sure, but the arch could plump up with what
Yeah.
they're doing here too. So
Well,
it'd be interesting to see.
we'll see what happens.
Okay,
I mean,
walk it up.
you know, take an angio down there selectively and see what you get.
Yep, that's what we're gonna do. We're gonna go ahead and get the microcatheter down and give lots of copious. Give me an O&A Trailblazer, guys.
and
PK, another question
and meds.
I know you're up and over in this case. Now, I mean, sometimes it's dependent on body habitus, but do you prefer an antegrade approach mostly for CLI, especially that you had, those tortuous iliacs? That must have been a beast to get up and over.
Yeah, no, Vishal can comment on antegrade. He loves antegrade. Myself and Karthik, we generally like being up and over.
Old school.
Or going, let's take a DSA, guys, or going retrograde through the foot. Ready for DSA? So I mean, the interesting thing will be, you're right, sometimes to cross this.
Some nitride? Yes.
To cross, I agree with you. Definitely antegrade would help. Ready, guys? Right here. Let's go inject.
Injecting. Yeah, I believe in antegrade aspect, especially the pushability, the getting the devices down, the length doesn't become a limiting factor. So if you get good antegrade access, I think it suffices and it really helps in your procedure, especially long CTOs. So
all right, so we've got
nice.
some better flow now, and we're going to go ahead and get our catheter down, and we're going to give some direct nipride, and then inject via the catheter and quickly go to the AT and cross the AT. I mean, I know Jazz is the master of CTOs and the coronaries, but I'm curious in terms of peripheral wise. Do you guys do a lot of this, like what we're taught? I'm taught by SS in terms of crossing these CTOs, with the wire choices. Are you using more peripheral wires or coronary wires to cross peripheral CTOs?
It's funny. We just had this discussion on Twitter. The coronary CTO wires work really well in the pedal space, but obviously now there are a lot of dedicated peripheral CTO wires as well too. For me, it's a mix and match of the two. I don't know about you guys.
I have to tell you, I never thought I would ever say this, but I've started using the Gladius 018.
That's a great wire.
Then of course you got to change out because a lot of the other stuff now you need to get an 014 wire to change out with. That's a great wire.
French.
Just pull back. It's a big.
Yeah, I used
it's a big
the 014 version is really good as well.
Yeah.
But the Command 18 and the Command ES obviously are fantastic wires. BTK, Regalia versus a Fielder XC. Fielder XCA being the coronary one, but the Regalia works well as well.
Some pain.
Mongo.
Yeah, Mongo's fantastic. I mean, it's a really good wire.
Mongo is like
it's
like a Pilot 200. The gram weight is Mongo is 3 and Pilot 200 is 4. So Mongo works good for
DSA is on.
Pretty well.
Yeah.
The other one I've used in some of the peripheral ones there, I've had terrible subtotal calcified iliacs that supply transplant renals. I do a lot of transplant renals, and we couldn't even get up with wires, so I had to come brachial and use via the Halbred.
Yeah, Halbred is great.
Halbred is very good because it actually navigates occlusions of calcium, and you can navigate through the lesion. So Halbred works very nicely. This is a straight shot. Looks good, guys. It's opening up.
Yeah, it's opened up nicely. So I think now we're going to concentrate. I'm going to take a shot from above, guys, and I'm going to start on the AT quickly. So give me some dive from here.
You want field up, PK?
Yeah.
Yeah.
Uh-huh.
You want the
dive?
Oh, you want to inject directly?
Oh, he wants to
inject from here. It's
catheter.
easier. Show me just so everybody can see the. Yep, that's good right there. Just make sure we didn't perf or anything like that. Sometimes.
It's a huge vessel.
All right, very nice. It worked out nicely.
That's very nice.
I think you're
So-
fine there. It's
Boy,
good.
this is amazing. This makes me feel like I should go and start doing peripherals again.
Absolutely. Are you kidding, Jazz? 100%.
You have to leave something for us.
All right, give me the fielder.
You can't take over everything.
So Jazz, I'm curious. I mean, you have a lot of experience with these peripheral wires. Obviously, with your knowledge, you know all this stuff. Do you see a big difference in torqueability in anything between the two types of wires, Jazz?
Right here.
Absolutely. So I think, these kind of lesions, you use confianza.
No, I need another
but
one.
I tell you,
Give me a new fielder.
very calcified iliac arteries, especially when they are bigger, your peripheral wires are much better. They perform much better than
New
the
fielder.
coronary wires, really.
So it's true what you're saying below in the iliacs. I totally agree with you. But what we find in the peripheral is we love the command, we love the connect. Those are the two families of wires we find the torqueability is really phenomenal. But hearing what Anish and Jay and George are saying, I definitely want to try these other wires because we have not tried these other wires. So maybe we're going to switch from being a coronary wire use below the knee to a peripheral wire use, which might be better.
Yeah, I would say Halberd is, I think, really nice over, I think, the Confianza. I mean, it's for those straight shots. It works really well.
Yeah, I use Helbrecht. I tell you, I've done 3 cases now that I couldn't do with any wire. I special ordered
Mag up on the
Helbrecht
trifigation.
and worked out beautifully. It really did very nice.
Let me do cath mode.
But it's amazing in the last couple of years, the
Go AP,
advances
guys.
in the peripheral
Off
wires.
fluoro?
There's a lot of really good peripheral wires now.
So George,
Gus, what do you think?
Go ahead, PK.
Go ahead. PK.
I'm curious on what George, in terms of these 018 Terumo style wires, what are you thinking about those, George?
I think they're good. I worry a little bit about how they can sort of escape into places where you don't want them. For whatever reason, the 018 Gladius seems to stay where you want it to stay, and it has a lot of body behind it. And so I don't find myself needing to always have a lot of support, in terms of support catheters. It just seems to really find its way down. But the Terumo wires are great.
You want to CSI that too?
I'm probably in the minority here too, but I use the 035
lower,
Advantage
please.
wire, and
I
I'll
wanna
even
see
take the 035 Advantage BTK. So I mean that's one of my most favorite workhorse wires. And
So you're comfortable with an 035 wire below the knee, really?
yeah, absolutely.
Wow, that's
and I'll tell you, it's I can control that thing. And now I've also used the 018 Advantage as
DSA?
well too, with good results. But I think again, I said I'm the minority for some of these peripheral CTOs. I mean, you knuckle that thing will go.
Yeah, but I used to always think you just had to be one or the other. And now I find myself using 018 all the time, and I never thought in a million years.
Yeah, but I tell you, I know that PTE, that you did. I think the 018 Terumo ain't gonna cross that. I think you needed a Confianza, something with a tip load that you did. I don't think it'll do it. What wire did you guys use to cross here? The same Confianza?
No,
we used the
this
fielder.
one we really felt was not difficult. That's one of the reasons why I wanted to do the other one first. This is just a bunch of subtotal lesions with a total distal. We just used a Fielder XT, and we're able to just
nice.
pummel it through as you saw. And now we're going to just put the Viper wire down distally in a safe. Well, that's not a safe area, and then go ahead and start doing our CSI here. Maybe we'll just leave it. I don't know why it wants to go there, but we'll just leave it there for now for sake of time. So we're going to run the CSI down here, George, and what we're going to do is balloon this, and then hopefully show a nice result with the balloon angioplasty. We have tack stents here if we need to tack. Obviously, I want to talk a little bit about below knee stenting with the DES versus now the Life BTK study, which Abbott has just started. I know that Jazz must have incredible experience. All you guys probably have incredible experience with the Resorb study in the coronaries. What are your thoughts with that study below the knee, and what do you guys think? Hold on, Flora.
So,
Yeah.
well, I mean, all of us up here participated in
Real?
Absorb, and so we're
Hold on,
biased
hold on,
and
wait.
know that it's a good product.
Yeah.
I think, but you know, 8 years
Okay,
ago,
good.
10 years ago, whenever it was, I thought that they needed to start with this platform in the periphery and below the knee, because when I came out of fellowship, one of my first cases, I did cipher kissing stents below the knee, and that stayed open forever. So the data on DES is good. So I think if you can get a DES-like result, but then it goes away over time, I think that gives you the best of both worlds, because I do understand vascular surgeons' concerns about crush and that sort of thing, even though I haven't really experienced a whole lot of that. But the idea that you could maybe go a little longer with something that's going to go away is appealing for sure.
Yeah, it's interesting. All of these BT, I mean, so we're in Saval, Illuminate, and Life BTK, and several other BTK trials coming up as well too. The big issue with all the BTK trials is just even getting these patients in.
Okay, now check.
Now, obviously,
I think you're
the
outside the
enrollment
site.
criteria is so tight. It's going to take a while, but I mean, it's attractive. I mean, all of these different devices have their pros and cons. Obviously, with any type of balloon expandable scaffold, you worry about the zones that you can actually put that in, but technically an absorbable scaffold is a little more flexible than a typical balloon expandable coronary scaffold. So we'll see how that goes.
That's good.
Obviously, Saval has advantage of being a self-expanding platform.
Yeah. So PK, what do you and Vishal and Karthik think? Do you have a set limit? You don't want to go beyond X amount of millimeters with the stenting, or does that?
Well, I'm going to ask Karthik and Vishal. I'll let Vishal work here with the CSI. Karthik, what do you think about BTK stenting? How do you decide?
I don't put more than 2 stents, Josh. So the maximum I would go is 38, so 96 max. 76 max.
72. Yeah.
That's it. That's the max I go. Now that we have 48 long stents, I can probably, but I limit myself to 2 stents as much as possible. Definitely not below the level of the distal third of the stent. Of course, I think that's standard.
Yeah.
So I would not go anywhere below that, but 2 stents only.
So
that's the data, right? That's the data would indicate that that's correct.
But I think George, changes with BTK.
Can you pan up,
right?
Karthik?
Yeah, PK.
Yeah, that.
Yeah, I just want to tell you, there's a stent inside the AT that had been placed in the past, and you were absolutely right. That stent remained open, but below and above it was above was stenosed, below is occluded, although subtotally. So now we're going to go ahead and just avoid the stent with the CSI and go a little bit above the ankle with the CSI, because right at the level of the bottom 1/3 of the AT, there's some stenosis.
You want to go with the stent?
No, I don't want to go with the stent. Below the stent. Below the stent.
He wants to do below the stent.
Below the stent.
We're going to walk it down.
So George, a couple of questions. I'm a big worrier about fracture, and when you have these bioabsorbable stents in the tibials, there is an amount of compression, even in the proximal, as you've seen by the multiple videos that we've seen of the SFA, as well as the popliteal on dynamic flexion extension of the legs. So I mean, theoretically, it sounds great to be able to remove, and the stent to disappear. I'm just a little concerned about this. Obviously, the increased MIs and other things that we saw in the coronaries is not going to occur here. But I am worried that there is going to be some disruption of these stents. Albeit we did not see it in the small studies out of Ramon Barco in New Zealand and Stephen Kum from Singapore.
No, that's the other.
So what are your thoughts on that?
So the thing is, you have to have a major fracture. The minor fractures of the scaffold don't really create a huge problem. And most of the coronary trouble was from under expansion and just not proper deployment. I mean, Jazz, you were in the study.
Yeah.
I mean, what do you think?
I'll tell you, with the imaging of these,
3035.
PK is right. I tell you, there was under expansion, then people started doing this PSP where they would, prepare, size and post dilate. But I will tell you, there were a significant amount of people in the imaging arm had these lumps of fracture that was in the lumen where they were more prone to thrombosis. And so, obviously coronaries are beating all day. And so you can have that. I mean, below the knee, it might not be that much of an issue.
The other issue is, at one time, and I haven't I haven't looked into this because I don't think they're using this for the trial, but at one time they had a self-expanding
Take 3035 or
3035, that's what I asked for.
and so you would kind of have that constant outward force, which would help versus a balloon expandable one that you have to smash into the vessel wall. So, the thing is, PK, it's kind of like the similarity between that and the coronaries is just that we know that the coronary DES work. I mean, we know the answer to that question. It's yes, they work.
Yes.
Now,
yes.
You just can't put too many of them in there, or you probably will run into trouble. Even though I will say that the IDEAS trial, which was completely insane, actually had pretty good results, and they did 110 millimeters on average of DES, which I would not recommend.
No, you see, even if you have fracture, what happens is the trauma causes intimal hyperplasia, and so thrombosis may not be as much, but the trauma and restenosis and TLR and all those kind of things we're seeing. But here, I mean, how coronaries move, and how below knee vessels move, right? So the chances of you having to create that much trauma and causing that much problem in the coronaries is not much. So I think there is promise. There is promise of this technology.
Got it. So George, we've taken a 3035. Let's go Mag here. Yeah. 3035 210 balloon, Flora. We did not IVUS. It was a very robust vessel, as you saw. So that's a 3.5 DES that we know that was placed in. Excuse me, 3.0 distally. 3.0. So we said, let's go ahead with a little bit larger balloon, 3.035, 210, and we're going to go ahead and just prolong balloon this and see how this turns out. So she is reacting now.
I'm just only like
at how many atmospheres?
8.
8 atmospheres. So it's fully expanded. We're just going to leave it up for a few minutes. Question to all of you. I mean, in terms of duration of balloon angioplasty, we learned from IMPACT, we learned from, actually all the DCB trials above the knee, that the PTA arm did very well because of the prolonged balloon angioplasty that we performed out to 3 minutes. So, maybe Karthik, Vishal, what do you guys think? I mean, in terms of balloon angioplasty and the duration of balloon angioplasty, how long do you guys leave the balloons up?
I think it's usually anecdotal. We leave it up anywhere between 2 to 3 minutes. But I think, like you said, rightly, it's the appropriate sizing of the balloon itself, which probably increases the patency of the vessel in addition to the duration. So I think IVUSing or sizing of the balloon and then keeping it up for 2 to 3 minutes to make sure we crack open and give enough compliance and opening up of the vessel. That's where my usual rough rule of thumb is like 3 minutes max.
Yeah, same here. I think most of the data came from SFA ballooning, right?
Correct. Yeah.
So it's like 2 minutes inflation. They said when we had PTA, when we didn't have bare metal stents, they said, okay, when you do PTA and you do 2-minute inflations, your patency goes up. That's what we translated onto the below knee inflations. But here we are talking about using a 300 millimeter balloons. So I'm assuming that when you use 300 millimeter balloons, you have to at least stay there for 2 minutes. You have to, because there's going to be multiple areas of occlusion which are going to be unexpanded. So I think just giving that much amount of inflation time is probably going to increase the patency. If it's a focal lesion, I think they just work just like coronaries. You just go in, break the lesion, and come out. I think the inflation time is mainly because of multiple areas of occlusion.
I guess the question I have for people is, how often do you use, or what's the role of atherectomy in these cases where there's calcification? Like chocolate balloon, angiosculpt.
Yeah. Oh yeah, this sort of disease, you have to modify it, and so atherectomy, absolutely, specialty balloons. And now, obviously, lithotripsy is another tool in our toolbox. So, yeah, you have no chance of just going straight PTA on something like this. So atherectomy is going to be a high percentage. What device you use just depends on whatever you're comfortable with. But yeah, absolutely, you've got to deal with the calcium before you do anything else.
Yeah. For this kind of case, I might have used at least in the AT, I might have actually used
proximal.
But the thing about it is, if you don't do debulking, you get barotrauma and you have an increased risk of dissections. And I think atherectomy,
walk back the guide.
By getting rid of that plaque, you may even reduce your dissection rates.
Yeah, I mean, that's the reason why I think the long inflation works, because if you understand the physics of
the guide.
You're right almost at the guide.
No, more.
At the primary area, you really don't heal the lesion,
the guide back.
And it'll go at the places where there's less
Go
resistance,
in with
so
the
it
balloon.
won't yield. And that's why I think in these kind of scenarios, specialty balloons is, most in coronaries, but angiosculpt and chocolate and stuff, because they transmit uniform pressure and uniform tension rather than having it at the edges and not where it's supposed to be, then I think there you can do nice inflations and not even long inflations, but they will yield and there'll be less flow limiting dissection. And that's why I think theoretically, that's why long inflations work. The other reason long inflations work is because I'll tell you, not only less dissections, but in vein grafts and in coronaries, in the old angioplasty days, people used to leave it up for as long as you want because you don't want a dissection. Number one, you create a lumen. And the other thing also, you don't have tissue prolapse. Like in vein grafts, you left the balloon up for a very, very long time. Stents, in vein grafts, you leave it up for a very long time because as soon as you do it, you get cheese grater. Things all come inside. You have tissue prolapse, and you have run the issue, those issues. So I think prolonged inflation is very, very important in these scenarios.
The other question though, Jazz, I think that's a very important point. Iris Baumgartner's group out of Switzerland did a nice study, which was published a few years back, that looked at recoil after what's it called? I believe it was 1 minute, 3 minutes, and 10 minutes. And what that study really showed is that you had up to a 50% recoil 10 minutes after the procedure was done. And I think that the shockwave balloon may play a role. As you saw, I'm going to IVUS this afterwards, but as you saw in the last IVUS that we did on the posterior tibial, the calcification is so great that if we're not truly affecting that calcium, either with enough rotational atherectomy or atherectomy, then we may need to really crack that calcium with some sort of lithotripsy to be able to prevent the recoil. So it's something that we don't look at. Nobody ever goes back and takes an angiogram 10 minutes after their balloon angioplasty because we move on to the next case. But I think in these kind of cases, you have to worry about this. And all your points are absolutely true. We know that the chocolate balloon reduces dissections, but do we know it prevents recoil 10 minutes later? And I think we don't know. So I'll IVUS this, and I'm just curious on your thoughts on probably a more expanded use for this lithotripsy in these type of calcific lesions. Even though the balloon size is small.
Yeah. So PK, I can tell you, I've had a handful of these lesions where I've gone up to just 2 atmospheres, and then you can see as you're doing the pulses that the balloon yields, that the balloon expands. Then you do your next set at 4 atmospheres. And so you can tell that you must be doing something to modify the plaque and modify the calcium because you've got a waste in the balloon that now all of a sudden is gone through a series of lithotripsy.
Shuttering.
Yeah, I think you're right.
Yeah, and then the recoil is a mechanism, not only what you do to the medial calcification and what you do to the adventitia. So
100
there
more.
is a small study that we looked at, with chocolate that it actually decreases recoil, much better than a conventional balloon angioplasty because of the way it allowed the injury to the media and the adventitia to heal because of the pillows and grooves. So that's what PK is saying is you want to make sure that you affect the compliance of the media and the adventitia to prevent recoil. And I think prolonged inflation, I think shockwave has a big potential. And I really do feel that the small pillows and grooves and with scoring, I think you affect the media and the adventitia stretching to prevent recoil. So have we studied it after 10 minutes? No, we have. But theoretically, I think it works.
So Jazz and George, and what we've done is we've given tons of vasodilators, and now we've given some what is it called, a verapamil as well. So we're going to do a quick IVUS now, and then before we do a picture, let her recover a little bit. Quick IVUS. Grab the IVUS right here. Here you go. So
what do you guys do you think there's going to be a paradigm shift for scaffolding these vessels versus moving away from drug-eluting technology, drug-eluting balloons for below the knee or drug-coated balloons below the knee? What's your take, PK?
Well, I was underwhelmed by the impact data that came out of TCT. I was hoping that we would have much better results. There's a new definition that they came up with to show that it was better than a PTA, which really is not a definition that you and I use. We obviously look at, the late lumen loss, so on and so forth, which really was not something that I was very impressed with, frankly. But I do believe, like George said, the DES data is so good below the knee. I'm very excited to see what Saval is going to show. I'm very, very excited to see what Life BTK will show with scaffolding, because I think the disease below the knee is really a more of a like Jazz was saying, recoil, as well as obviously, what is it called, reduction in the lumen post your initial procedure. So I think some sort of scaffolding would really help below the knee. So me personally, the TOBA 2 study came out. It's a nice results, but obviously it wasn't compared to anything, which I never understand why they do that. But at the same time, at least you have some exciting data that looks at that spot stenting may also work. So to answer your question, for me, I really believe that scaffolding is going to be the future below the knee.
Yeah. So PK, I was watching the IVUS go down, and without
slow
joking, but kind of joking. I mean, you've cleared out a nice tube there in what is still all calcium. So, what would be the mechanism of something coming through all of that calcium, to re-narrow it?
I'll tell you, what happened here. I think this vessel was underexpanded and subtotally occluded.
Yeah.
And there was not much plaque in those areas that you guys were downstream. So you guys did an amazing job. That old stent actually looked pretty good.
Yeah.
And this area, I think it just opened up and you cleaned up with balloon and CSI in this area right here. You see how good the cut is?
Yeah.
And you really don't have the sections. You don't have the sections. There's the section there, but nothing really. I mean, the lumen looks amazing. That's your stent.
Yeah, look at this.
And look at this stent. This stent, I believe, was put about 2.5 years ago, right? And absolutely no restenosis, and obviously no compression at this site, no stent fracture here. So I don't know. I mean, Jay or Anish, I forgot who asked me that question. I really believe that scaffolding is going to play a major role for us below the knee. What I really want to see is some head-to-head studies. I mean, we're all cardiologists that we're discussing this, and I can tell you that it's so nice in the coronaries. We can look at one another and say that, hey, this study said that this is better than this in this situation. But here as endovascular interventions, we can't say anything. We can say what we think, what we feel, but there's no hard data, and I find that very frustrating with people like Sriya and other fellows who are training, who ask such intelligent questions, and you're kind of at a how can you say, impasse in how to answer that.
Yeah.
I don't know, guys, but I feel like the DES is patent because it's DES. I don't know if it's a bare metal platform giving you a scaffold. I don't know what the patency is going to be for below knee vessels. What do you guys think?
Laura?
Yeah, it's hard to predict.
Yeah, so I'm saying if you're using TAC or any other bare metal stenting, I don't know what the patency is going to be for below knee. Just like the coronaries, you're going to have much more amount of restenosis in bare metals. Or DES, I think the patency is because most of the BTK studies were done with DES.
Right. The good news is from an economic standpoint, DES are now cheaper than bare metal coronary.
Yeah, that's right.
So
that's probably that's true. Scaffolding always gives you an advantage till now as compared to drug core itself.
Yeah.
All right, let's take some
actually,
pictures.
George, that only makes cath lab directors like Jazz and Sharma and Kinney happy, not guys like us.
Yeah.
All right, so here's a picture. Again, looks like, let's see.
Beautiful.
It looks
good. A little bit better. The arch is starting to fill here. But you see that it's this microvascular disease is so difficult to treat.
Take the wire out, Vishal.
To pull the wire back a little bit. I'm going to give the only question here is whether we should do any work on the level of the arch. So let's put a catheter in and inject into the arch, and then I want to see whether there's flow.
035. Give me.
I'm just going to give another picture now.
018 is fine. Yeah. If you have to work on it, then we'll probably take it.
So the posterior tibia is robust. And the AT, it's much better now. But you see the arch is very poor there. And the question is whether I'm going to go down now with a catheter and I'm going to give copious vasodilators in the dorsalis pedis because it's the first phalangeal artery that I'm concerned with. And I want to see how that looks.
No, give me an oven. Just oven.
So we're just going to go ahead now and do that.
Perfect.
Yeah, so PK, I think this is the part of the CLI case where I think some of these instruments to give you an idea of live tissue oxygen perfusion are a good idea because, again, you're trying to get enough oxygen here to heal, and you don't know for sure at this point if you do or not. And what you're proposing is great in your hands, but not everybody should immediately decide to start messing around with arches, especially once they've gotten two tibial vessels open like you have.
I think this is like a PK. This is like a reperfusing an infarct that you are trying now. The microvessels are all clogged up, and you're trying to open them up. And you guys have opened it up. The thing is, you have to realize that she has an ulcer. She has inflammation around those vessels. It's going to be very hard for you to really have a complete, like we call TIMI-3 flow in there. So I think you guys have done pretty good. And obviously, I'm not experienced enough in these kind of things. But when I look at what you have achieved right now and what tissue this is going into, I think you guys have done an amazing job. I really do.
Yeah, I agree.
So that I think this really highlights. I mean, Jazz, what you're saying is absolutely true.
Sorry.
It's so funny. We all use the word TIMI-3 flow. That. There's never been a real quantification of flow in the periphery. So it's very hard, and this is the challenge we face, Jazz, because when do we stop? When do we say, hey, this is enough? And unfortunately, like George highlighted so nicely, we don't have a perfusion assessment that's reliable. Philips has played with some software. You're giving it vasodilation. Philips has played with some software and other things, but we really don't have it. We have obviously thiocyanate green. We have TCPO2. All these kind of experimental stuff that all of us have tried, but never really anything that works. I do want to just comment on one thing. I know it's getting close to time. You guys tell me when I should shush up. Is that this whole concept of bad artery disease and sad artery disease, right? So this is obviously Roberto Ferrarisi, out of Italy, a good friend of ours here, came up with this idea that we're basically treating obviously big arteries, but when you talk about these microvessels in the foot, it's obviously very, very challenging, and it goes to what Jazz says. So you can see here we're barely perfusing the great toe, and I think if we go back to the picture we took with the posterior tibial, I want to show you that. I think that may be enough to be able to heal this wound. I'm just going to go backwards here. Ray, can you show me how to go to the posterior tibial?
George, would you guys go to the first digital artery and probably do like a 1.5 and open up that hibernating vessel? Or
No, sir.
Yeah, no, sir. You're gonna get in trouble.
That's right.
No, I agree. I wouldn't either. So you see, the posterior tibial is filling, the anterior tibial is filling. I mean, I agree with what Jazz said. We gotta trust. Liz, can you pull up my mask? We gotta trust our results in terms of how we've done, and we're gonna leave this up to good wound care. So I mean, if it's all right with you guys, we're gonna stop here.
That's great.
I agree. I think
good job as usual.
The comment you made that about sad versus bad, I think that's so applicable in this case. I think this patient definitely has, a certain degree of small artery disease that no matter what, you're really not going to affect. I think you've opened the big arteries. The lateral plantar into that arch was poor. I don't think there's any way you're going to get much out of it. So I think this is the right place to stop. And that was an awesome case. And, great job, you guys.
Well, thank you.
Excellent job.
Well, thank you, George. And honestly, from the three of us here and our entire team at Sinai, really want to thank you and especially Jazz. First of all, Jazz, I didn't know. Congratulations for putting it on in such a difficult circumstance and running such a great conference. And we hope to see you in the future. We'll definitely see each other in some conferences and hopefully face to face rather than virtually. So from New York, thank you again very much.
Thank you.
Thank you.
All right, good job, guys.
Good job. Thank you very much.
Great job, guys.